You have time to read the questions before you hear the extracts. You will hear each extract once only. You have to complete your answers as you listen. At the end of each test, you will be given 2 minutes to check your answers. Part A. In this part of the test, you hear 2 different extracts. In each extract, a health professional is talking to her patient. For questions 1 to 24, complete the notes with the information you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. You hear a doctor talking to a patient called Metagal. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, Doctor.
Good morning. Please be seated. Can you tell me about your problem?
Doctor, since last year, I've been having double vision whenever I wake up in the morning. The problem lasts for 1 hour after I wake. When I close my eyes, the double vision dissipates. Over the past month, the double vision problem has worsened in intensity and frequency. I approached a local hospital in my town, and they referred me to the emergency department for an urgent MRI to investigate for possible aneurysm. There, I had a normal MRI and I was discharged to go home. By the next week, the double vision improved, although at present I'm still experiencing constant diplopia. In the past, whenever I saw 2 objects, they were very far apart in horizontal plane, but now the objects appear much closer together. I've stopped driving. I've also discontinued my job due to the diplopia problem. There's no temporal fluctuation to the double vision. Very recently, over the past week, I've developed supraorbital pain on the right side.
Your age?
51, Doctor.
Do you have any problems with swallowing or dysphagia?
No, Doctor.
Any weakness, numbness, tingling, or any neurological issues?
No, Doctor.
Do you have any difficulty in speaking or dysarthria?
No, Doctor.
Are you on any medication or allergic to any medicines?
No, Doctor.
Do you drink or smoke?
I do not drink, but I smoke.
Is there any family history of any illness?
My mother died of a stroke when she was 90. My father had colon cancer.
Well, your physical examination report shows your BP 124/76, heart rate 101, respiratory rate is 20. Your recent MRI report shows a questionable 3 mm aneurysm of the medial left supraclinoid internal corduroy artery. There is absolutely no abnormality on the right side. The blood flow patterns are normal and there is no blood vessel abnormalities. I think you have developed a condition myasthenia gravis or other disorder. Your right lid process. You have left gaze diplopia. The pupils are equal and reactive to light. Your neurological investigation is absolutely normal. There are possibilities of other extraocular abnormalities. You have horizontal diplopia in both directions, but there is no vertical diplopia. You have monocular diplopia.
Is it curable, Doctor?
Yes, of course. I would advise you to have a craniotomy and clipping done. This is a surgery performed to treat an aneurysm. However, you have to be very careful after the surgery because a rupture may cause you to lose your vision.
I think I should go for this surgery at any cost, Doctor.
You are right, Mr. Metagal. Extract 2, questions 13 to 24. You hear a physician talking to a patient called Mr. Medhigu. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Good morning, Mr. Mahigu. Be seated. Tell me about your problem.
Doctor, I wanted re-evaluation of possible idiopathic normal pressure hydrocephalus.
Okay. What's your age now?
I'm 80, Doctor.
May I know when and how you developed this illness?
Well, it started 12 months ago. I had severe cognitive impairment, gait impairment and incontinence. Actually, I was evaluated in hospital at the time with CSF drainage via temporary spinal catheter, but there wasn't any significant response for that.
Well, your MRI shows you have cervical stenosis. It seems you also had a cervical laminectomy and instrumental fusion 6 months back.
Yeah, but there's no significant improvement. I think I've become worse now than I was a year ago. Practically, I'm unable to walk at all. I use both a walker and a support from an assistant to be able to walk or stand.
Do you have any headaches?
No, Doctor. I think my memory has worsened.
What medication are you taking?
Aricept 10 milligrams in the evening, carbidopa 25 milligrams or levodopa 100 milligrams 3 times a day, citalopram 40 milligrams daily, Collis 100 milligrams twice a day, finasteride 5 milligrams once a day, Flomax 0.4 milligrams once a day, multivitamin with iron once a day, omeprazole 20 milligrams once a day, Senna 8.6 milligrams twice a day, Tylenol 650 milligrams as needed, and promethazine 25 milligrams as needed.
Your cranial nerve exam shows there is no up gaze that I can extract today. The down gaze and horizontal gaze are intact. Your gait is severely impaired. I have reviewed your CT scan of your brain and compared it to the MRI scan taken 8 months ago. Now I can see that the ventricles appear larger. The frontal hall span was previously about 5.5 centimetres and now it is 6 centimetres. The third ventricular span is 15 millimetres. I have come to the conclusion now that you have idiopathic normal pressure hydrocephalus. There is a possibility of supranuclear palsy, incontinence and urinary urgency. Although you have already had a CSF drainage via spinal catheter a year ago, I would strongly recommend that you repeat this now because there is further enlargement of the ventricles on the scan. I would also recommend a shunt surgery that would probably make a difference. That is the end of Part A. Now look at Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at question 25. You hear 2 doctors discussing the new device to ease breathing difficulties in patients with chronic obstructive pulmonary disease. Now read the question.
Doctor, what about the new device that will ease breathing difficulty in patients with chronic obstructive pulmonary disease?
Decreasing the volume of lungs affected by emphysema or chronic obstructive pulmonary disease actually makes patients with the condition breathe more easily. If they take a breath, due to the lung capacity, it causes shortness of breath. When we take a deep breath in, if it is hard to breathe up there, this is called shortness of breath, which our patients often experience. Therefore, reducing the lung volume significantly improves the quality of life. The new device resembling a valve is used for achieving this, and this is being tested in the US. Question 26. You hear a doctor explaining to his nurse about functional gastrointestinal disorders. Now read the question.
Hello, doctor. Can you explain to me about functional gastrointestinal disorders in patients?
Well, functional gastrointestinal disorders is common in my daily clinical practice. This is characterized by difficulties in motility patterns and visceral hypersensitivity. If the patient is bloated and gassy, you should get them treated before the condition progresses. Bloating after meals, loose stool, constipation and gas are the minor symptoms of functional gastrointestinal disorder, while acid reflux, foul-smelling gas and abdominal distension are major symptoms of the disease. The symptoms such as foul-smelling sticky stool, hematochezia and the sense of urgency to defecate are the severe symptoms of the disease. Question 27. You hear two doctors talking about the differences between conductive and sensorineural hearing impairment. Now read the question.
Hello, doctor. Can you differentiate between conductive and sensorineural hearing loss?
Well, conductive hearing loss occurs when a person experiences a difficulty in conducting sound waves anywhere along the route through the outer ear, meringa or tympanic membrane or middle ear. This may occur in conjunction with sensorineural hearing loss as well. While the root cause of sensorineural hearing loss lies in the sensory organ or inner ear called cochlea and associated structures, or the vestibular cochlear nerve or neutral part, about 90% of hearing impaired patients are of sensorial hearing loss. However, this can be mild, moderate, severe or profound. Question 28. You hear a doctor briefing a junior doctor about eczema. Now read the question.
Hello, doctor. Can you please brief me on eczema?
Atopic dermatitis or eczema is a type of skin disease that causes an itchy, non-contagious rash. It can affect people of all ages, however, it is most common in children. For some people, it is a lifelong problem. Eczema is considered as an inherited health issue and associated with food allergies, asthma, and allergic rhinitis. Normally, this condition occurs when the skin is inflamed and could not retain sufficient moisture. The condition is aggravated by moisture from sweating or humidity and by extreme dryness and coldness. The condition is also caused by stress, irritants, and specific foods or dusts and molds. Question 29. You hear a doctor's dialogue on the vaccine for hepatitis B virus. Now read the question. For patients with advanced chronic kidney disease, including hemodialysis patients, a higher dose of hepatitis B virus vaccine is recommended. A higher dose vaccination may improve the immune response of the patient significantly. The hepatitis B surface antibody titer should be monitored 2 months after completion of the vaccination. Thereafter annually, with a target titer of 10 international unit or 10 mil. The vaccination schedule should be repeated if the patients do not develop a protective antibody titer after completing the initial vaccination schedule. Question 30. You hear a doctor explaining to his patient about a bone marrow biopsy. Now read the question.
Doctor, I was told to undergo a bone marrow biopsy and I'm very worried about this test. Can you suggest how I need to prepare for this?
Well, a bone marrow biopsy is normally advised to diagnose and monitor a variety of conditions. It can also be performed to diagnose or determine the extent of certain types of cancer. A bone marrow biopsy is performed through the procedure called a bone marrow aspiration to obtain a sample of the bone marrow, which is the blood-forming portion of the inner core of the bone. Usually, a bone marrow aspiration is taken from the pelvic bone called the ilium. That can be accessed from the lower back near the hip. The sample can also be taken from the center bone in the chest called the sternum, or the front of the pelvic bone near the groin. That is the end of Part B. Now look at Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear the doctor briefing his staff about the pathology report. You have 90 seconds to read questions 31 to 36.
Hello, Doctor. Will you please explain to me about the type of information included in a pathology report?
Well, often a pathology report of surgical specimens is complex and very long. These are divided into many subheadings. The general information includes the name of the patient, the medical report number, the date of the biopsy or surgery, and the unique number of the specimen that is assigned in the lab. The next set of information often contains patient information provided by the doctor who resected the tissue sample. This information includes the special requests made to the pathologist and the medical history. For instance, if a lymph node sample is being resected from a patient with cancer in another organ, the doctor will indicate the type of the original cancer. This is useful in guiding the pathologist's selection of special tests that may be required to assess if any cancer in that lymph node is a metastasis from the original cancer, or else a new cancer that started in the lymph node. Gross description is the next part of the information. Here, the term gross means the details seen without using a microscope, by simply looking at it and feeling the tissue sample and measuring. In the case of a small biopsy, the gross description would be a few sentences listing its colour, size and consistency. Gross description would also include the number of tissue-containing cassettes submitted for biopsy. However, in the case of a larger biopsy or tissue specimen, for instance a mastectomy for breast cancer, this will have lengthy gross descriptions, including the size of the entire piece of tissue, size of the cancer tumour, how close the cancer tumour is to the nearest surgical margin of the specimen, how many lymph nodes were detected in the underarm area, and the particulars of the non-cancer tissues. A note of where tissue was taken from is also included. The gross description is very short for cryptology specimens. That usually notes the number of smears or slides made by the doctor. If the specimen is a body fluid, its volume and colour are indicated. Microscopic description will include details such as the appearance of cancer cells, how these cells are arranged together, and the extent of invasion to the nearby tissue in the specimen. Results of any other investigations made, such as flow cytometry, histochemical, etc., may be indicated in the microscopic description or in an exclusive section. Diagnosis is the most significant part of the pathology report. Although this is the bottom line of the pathology, this section can be mentioned at the top or bottom of the report. The doctor relies on this final diagnosis information to decide on the best treatment methodologies. In case the diagnosis is made for a cancer tumour, this section will indicate the exact type of cancer and will include the grade of cancer. Once the final diagnosis is complete, the pathologist may want to include any additional notes for the doctors taking care of the patient. Often this comment section is used to recommend further diagnosis or to clarify a concern. Now look at Extract 2. Questions 37 to 42. You hear the doctor giving a lecture to the junior doctors on lung carcinoid tumours. You have 90 seconds to read questions 37 to 42. We all know that cancer begins when the cells begin to grow out of control. Cells in any part of our body can become cancer and can metastasize to other parts. Significantly, lung carcinoid tumours are uncommon and grow slower compared with other types of lung cancers. Lung carcinoids are made up of special cells called neuroendocrine cells. Before we try to understand lung carcinoid tumours, it is essential to know something about the structure and functionings of the lungs, as well as the neuroendocrine system. Our right lung has 3 sections called lobes, and our left lung has 2 lobes. The left lung is smaller because the heart takes up room on that side. When we breathe in, air goes into the lungs through the trachea. The trachea divides into tubes called the bronchi that enter the lungs and further divide into smaller branches called the bronchioles. At the end of the bronchioles, there are tiny air sacs called alveoli, from where many tiny blood vessels run through. These blood vessels absorb oxygen into the bloodstream and pass carbon dioxide into the alveoli, which is exhaled. Therefore, the main function of the lungs are inhaling oxygen and exhaling carbon dioxide. A thin lining, known as the phleura, surrounds the lungs, which protects the lungs and helps them slide back and forth as they expand and contract while we breathe. Phleura capacity is the space inside our chest that contains the lungs. A dome-shaped thin muscle called the diaphragm below the lungs, which separates the chest from the abdomen. Therefore, while we breathe, the diaphragm moves up and down, forcing the air in and out of the lungs. Lung carcinoid tumours develop from the cells of the diffuse neuroendocrine system, made up of the cells that are similar to nerve cells and hormone-making endocrine cells. These cells do not form an actual organ like the thyroid or adrenal glands. Instead, these cells are scattered throughout the body in organs such as the intestines, stomach, and lungs. Neuroendocrine cells secrete hormones such as adrenaline and similar substances. This may help control airflow and blood flow in the lungs and may help control the growth of other types of lung cells. Neuroendocrine cells may detect the oxygen and carbon dioxide levels in the air we breathe and then discharge chemical messages to help the lungs adjust accordingly. For instance, people living at higher altitudes will have more lung neuroendocrine cells because of the decreased oxygen level in the air they breathe. At times, lung neuroendocrine cells undergo certain changes, causing them to grow big and form tumours. These are known as neuroendocrine cancers. Lung carcinoid tumours are a kind of neuroendocrine tumour. However, neuroendocrine tumours can form in any part of our body. Stomach is another common site for neuroendocrine tumour formation. There are 4 different types of neuroendocrine lung tumours. Starting with the aggressive growth of the cancer, the 4 types are small cell lung cancer, large cell neuroendocrine carcinoma, atypical carcinoid tumour, and typical carcinoid tumour. Small cell lung cancer is one of the aggressively growing and spreading tumours. Large cell neuroendocrine carcinoma is a rare type of cancer. It is a subcategory of non-small cell lung cancer, though it grows aggressively like small cell lung cancer. Typical and atypical carcinoid tumours are carcinoids that appear different under the microscope. Typical carcinoids grow slowly and they rarely spread beyond the lungs. 90% of the lung carcinoids are typical carcinoids. Atypical carcinoids grow a little faster and they are likely to spread to other organs. They contain more cells in the process of dividing and they appear more like a fast-growing tumour. Unlike the typical carcinoids, atypical carcinoids are uncommon. At times, carcinoids are classified by where they develop from inside the lung. Central carcinoids form in the bronchial walls near the centre of the lungs, and most lung carcinoid tumours are central carcinoids, which are also typical carcinoids. Peripheral carcinoids form in the bronchioles, towards the outer edges of the lungs. That is the end of Part C. You now have 2 minutes to check your answers.
That is the end of